What I'm going to do today is not go through a laundry list of all the potential candidates for left atrial appendage occlusion, but rather share with you some special considerations perhaps that you've not thought about. And I'm going to look at it from 4 different perspectives. So we're going to talk mostly about a clinical perspective, but I'm going to switch gears then and talk a little bit about looking at who to close from an anatomical and physiologic perspective, and then maybe even touch on some regulatory issues and some hospital administrative issues. So from a clinical perspective, far and away, the number one consideration, in my opinion, should be those people that are unprotected. And that's a lot of people. This is warfarin data, Medicare claims data showing, everybody knows this, that about 40–50% of patients are untreated. And in fact, the people that are at the highest risk, like a CHA2DS2-VASc score of 6 or older patients, are the least likely to be protected. And with the initiation of the DOACs, things have gotten a little bit better because they're easier. People don't have to take warfarin, all the hassles of warfarin. But essentially, there's been about a 5% improvement in people covered in the NOAC era, and that's still unacceptable. This slide is from the Pinnacle Data Registry. You've already seen a little bit of this presented earlier. And this is very striking because, again, it shows that about 40% of patients in contemporary cardiology practices are not treated. And what's also striking about this is the variability depending on which site you are. It looks like site number 1 is doing a really good job, and site number 121, maybe not so much. And so this is kind of a graph that shows, based on your CHA2DS2-VASc score, what your risk of ischemic stroke would be, untreated, okay? And this is the line of warfarin efficacy, right? And then what this does, and again, you've seen this before, is this is how all the trials, both the registries and the trials and the for the Watchman device map out. And I would submit, okay, that the red line is unacceptable. So if somebody is untreated, there are better options. Okay. Now what we've done at the Mid-America Heart Institute in Kansas City is we've come up with this best practice advisory. This is in-house designed, and so when we have a patient in the clinic that has a CHA2DS2-VASc score of greater than or equal to 2, okay, you can't get out of your EPIC record without this box coming up in front of you. And what this does is it helps facilitate and acknowledge, what's going on. And it also sets up a process where you can, order, refer to a structural clinic. You can actually say, oh, we missed that one, open up the anticoagulation order set, et cetera, et cetera, et cetera. So I think this is going to be potentially something that is going to be very useful to identify patients that can benefit. So from clinical perspective, number 2, of course, is bleeding, okay? And people that have already had bleeding events, that's pretty simple. What about people that are at a very high risk of bleeding? And the challenge with this is this, okay? So there's actually 10 models that are out there to predict risk of bleeding with 30 different variables, okay? And the one that everybody talks about is the has-bled score, but I would submit that it's really, really hard, if not impossible, to really predict who is at high risk for something that might not happen. So I'm going to talk about a few special considerations in these high-risk patients that I want to bring to your attention. Number 1, okay, is the elderly with cognitive impairment, okay? These are patients that have a high likelihood of cerebral amyloid angiopathy. These are 75 or older year patients with dementia, and if you look at autopsy studies, it shows that a significant number of these patients have CAA. And of course, this data shows that most of the patients that you see with atrial fibrillation are over the age of 75. And so I would submit that it's very important that you have a team-based approach with your neurologists and dementia neurologists to identify patients potentially are untreated because of this. The second issue that is really challenging for me personally is this whole notion of vasculopaths. Okay, people that are on dual antiplatelet therapy and they come in and do you treat them with triple therapy or what? Now, with the Pioneer data and all the other data, this is very, very confusing and difficult to sort out. But I would submit that, again, looking at the Pinnacle registry, if you look at the people that in those 40% of patients that were not treated, the reason that they weren't treated is because they have unstable angina, coronary disease, PAD, prior CABG. And so I think these patients that we feel need antiplatelet therapy, and dual antiplatelet therapy might be a special consideration. The last one, from a high risk of bleeding perspective, is just the opposite. I would submit that a lot of people are putting these devices in because of frailty, but if you actually look at the data, it takes over 1,000 falls before the benefit-risk ratio switches over. So really, I think that frailty is okay, fall risk is okay, but that's probably something that we should really ask ourselves whether these people really genuinely have contraindications to anticoagulation. So lastly, the clinical perspective is what I would term pharmacotherapy challenges. There's two types. There's adherence. Okay, we know that for the fact that people just don't take their medications. So again, if patients are unable to take their medications, they're unable to afford these medications, that's a special consideration. And then the other one that I think is very interesting is adequacy. Okay, because a lot of patients, I'm seeing a lot of patients that are relatively undertreated, okay, because the scenario is, oh, they've had a bleeding event and they were on full dose, but maybe let's try low dose anticoagulation. And so the question is does that work? And in fact, if you look here in the Aristotle trial, 5% of patients actually met the criteria for low dose apixaban, but 25% of global prescriptions are actually for 2.5 BID. And so maybe that's better than nothing, but I don't think we have the data to necessarily support that. So let's move on to anatomic and physiologic considerations. Okay? Now, there's a lot of good data out there that really is looking at, the pathology and the pathophysiology of that correlation of atrial fibrillation and stroke. And we know that left atrial remodeling with increased left atrial volume, increased left atrial fibrosis, and decreased left atrial function are important predictors, independent of the CHA2DS2-VASc score. This is all the data that shows that LAA function and LAA morphology and orifice area and fibrosis actually matter. And so one of the factors that I factor into these patients in terms of choosing whether to close somebody or not is not just based on the CHA2DS2-VASc score and their clinical criteria. It actually is very helpful if they have an echocardiogram and you can see what their left atrial appendage looks like. Because if you look at this data here, okay, the biggest strokes occur in patients with low emptying velocities and large diameter appendages. And so again, I think it's a special consideration and a factor to consider. And of course, the morphology, there's data to show that the chicken wings are less likely to have strokes than the other types. But again, I think we're going to learn more over time of getting even better at predicting who would benefit the most from these therapies. The last one from a physiologic perspective is this data, and I really struggle with this as well, and it's scary data to me. This is from the Aristotle trial showing that actually if you look at these different quartiles of biomarkers, and this particular one is NT-proBNP, you can see that somebody with a CHA2DS2-VASc score of 3 with the highest quartile of proBNP is actually at a much greater risk of stroke than somebody with a CHA2DS2-VASc score of greater than or equal to 5 with no biomarkers. And I have yet to figure out exactly how to integrate this data in my decision making in terms of who to close or not to close. Obviously we have the ABC risk factor, but again, I'm not using that on a regular basis. I'm trying to figure that out. So from a regulatory perspective, you saw some of this also earlier. We know that Medicare coverage matters because we have to get paid for this device. And these are the three things that I think you need to consider. Okay? So this is a flip side of it, is these are people that I will not close unless these three things happen from a regulatory perspective, because I don't look good in orange. Okay? Number one, eligible patients must have a CHA2DS2-VASc score of greater than or equal to 3, not 2. Number two, they must be suitable for short-term warfarin but deemed unable to take long-term oral anticoagulation, but this decision should be made primarily by a, quote, independent, non-invasive physician. Okay? So again, documentation of the electronic medical record that somebody other than me, okay, has opined on this and has felt that this patient needs to be considered for, is not a good long-term anticoagulation candidate, is very important to document. And then there must be a documented formal evidence for a formal shared decision interaction. And this is one that I use. I actually show this to patients and to educate them that here's your appendage, and the anticoagulation prevents the clot from forming in your source, and what the Watchman device does is it actually eliminates the source. So these visuals for patients from a shared clinical decision-making perspective, I think are really, really valuable. And then I use this 3-door approach. So I talk about the risk of doing nothing is door number 1, the risk of going on anticoagulation or restarting anticoagulation if they've had a bleeding event is door number 2, and door number 3 would be the Watchman device, okay, or left atrial appendage closer. And so we talk about the risks of doing, to begin with, and then we'll talk about the benefits and the risks of each one of those 3 therapies, and I think this is a nice tool for patients and their families to visualize, and then they can pick. Okay, door number 1, and most of the patients that are older that are in their 70s and 80s love this because they used to watch The Price is Right, and they can choose door number 1, door number 2, or door number 3. So lastly, I'll finish up with a hospital administrative slide. I only have one slide on this, and it's all about the money. And I can tell you that in Kansas City, our market is one where we don't get paid a lot for this device, and it's very regionally different. Depends on if you're on the East Coast, the North Coast, the West Coast, North, South, East, and West. And I would submit that it's a consideration that a lot of hospitals and administrators are looking at kind of the relative benefits of this because it is resource intensive, and sometimes the reimbursements aren't what we all think that they are. And so, again, looking at it through a different lens. So in conclusion, I think clinical considerations, number 1, are unprotected patients, and if you come up with a best practice advisory, using your EMR the way it should be used to identify patients that might be very helpful. Prior bleeding history is kind of a low-hanging fruit, but high risk of bleeding I would submit is very, very challenging. But elderly with cognitive impairment, I think you should pay special attention to. The vasculopaths and frailty. The pharmacology issues, adherence, and adequacy are very important. I think beyond clinical characteristics, anatomic and physiologic considerations should be considered. The size, the shape, the function, biomarkers, regulatory considerations, of course, are important. And as a physician, I don't really care about the administrative considerations, but being the executive medical director of the Heart Institute, I have to care a little bit about these kinds of things. And so make sure you do your due diligence from that perspective. Thank you very much.